everyone. My name is Bree Kimberling. I am a community health nurse here at North Kansas City Hospital, and thank you all for joining us. Today we have a great presentation, something I'm interested in, non-statin treatments for high cholesterol, and our speaker today is Mikayla Montoya. She's a clinical pharmacy specialist at North Kansas City Hospital. She currently works on the cardiac progressive care unit. She's earned her doctorate of pharmacy degree at St. Louis College of Pharmacy, and she completed her PGY1 pharmacy residency at Missouri Baptist Medical Center. So again, thank you both for joining us and for presenting today, Mikayla. We do have the Q&A open, so if you have questions, please type those in there, and I'll keep an eye on that, and I can notify Mikayla if we have a question come up. So I will turn it over to you.
Sounds great. Thank you, Bree. So today we're going to talk about kind of background on cholesterol, why statins are the cornerstone, and then the future of non-statin treatment for high cholesterol. So to start, just some information on cholesterol. So what is it? So it's a small molecule that your body naturally makes in the liver. It can also be introduced through your diet. So we do need some level of cholesterol in the body to make certain hormones that are required for human body processes. The main cholesterol molecules that we talk about are lipoprotein carriers, and they move the cholesterol around your body, so they're in your bloodstream. So we talk a lot about low density lipoprotein, or LDL, and that's classified as the bad cholesterol generally. And then we talk about high density lipoprotein and HDL, and that's the good cholesterol. They want to see the LDL number be low, and they want to see the HDL number be on the higher side, usually above 40 for men, above 50 for women. We also have triglycerides in our body, and these are generally used as just energy sources. They can build up to dangerous levels, though, so it's something that they do monitor. We do obtain levels to see what's going on with these different cholesterols in your body. So we do that through blood draws. So when we get a baseline, then we check again, usually 4 to 12 weeks after we change therapy or increase therapy. And then once you're stable on a medication, we'll check every 3 months to a year, depending on what's going on. So when we do these labs, a lot of times they'll ask you to be fasting. You don't always have to be fasting. So if it's a baseline, they'll generally just say, just go get your labs drawn. We need a fasting for patients who we do have concerns that the levels might be high, or if they have proven to be high. When we do a repeat, we do want these patients to be fasting. So how do you get high cholesterol? So a lot of it is going to be through your diet. So as I mentioned, it's introduced through diet and through your body making it. So besides diet, lack of exercise, being overweight or obese, smoking, alcohol use, and some unfortunate family history can cause patients to just have naturally high cholesterol. I'm interested in this topic because I kind of fall into that family history category. My father had to have an open heart surgery when he was only 52. So sometimes patients, no matter how much you try with diet and exercise, you're always going to be having that family component kind of work against you. So what is the risk of high cholesterol? So we worry about the high cholesterol because it's kind of a surrogate marker for what's going on inside your body. So we can't always see, just looking at a patient, what's going on inside those vessels. So you're going to see what a clean vessel, it's a normal blood vessel. So sometimes we can get tears in the artery wall, and then we kind of get these formations of these fatty deposits, which we can call plaque. So these plaques narrow that vessel, so we're not getting as much blood through. And then if you happen to get like a small blood clot or one of these plaques rupture, we completely cut off that blood flow to a specific area. So when we have these blockages, they usually can kind of start off as chest pain. So that's when we just have the deposits there that's limiting the flow. So that can cause just pain in the area from the limited flow. Generally, when we move to heart attack, that's going to be some sort of complete occlusion, either of a small vessel or a large vessel in the heart. The severity of the heart attack depends on which vessel is occluded. Stroke is going to be occlusion of a vessel in the brain. And then peripheral vascular disease is going to be when we have occlusions of vessels in the legs generally. So who needs medications to lower cholesterol? So anyone that's had a serious cardiac event, so a heart attack, patients that have had a history of a stroke, If you're one of those people that have the familial hypercholesterolemia, so you have that high cholesterol from family component, you have just high cholesterol levels. Generally, we want levels less than an LDL level less than 100. So these are going to be patients that have LDL levels greater than 190 at baseline with no medication. And then some diabetic patients, we do want to be a little bit stricter on their LDL levels, just because they already have the diabetes that can kind of damage the blood vessels if the blood sugar is uncontrolled. So we want to make sure that we keep the vessels in as good a shape as possible by not getting those plaques built up. So next, we're going to kind of talk about the standard treatments. So the standard non-medication treatments are going to be a heart-healthy diet. So that's going to be the best way to lower your cholesterol without medication. So we're going to reduce saturated fat and trans fat. And that's generally going to mean less fatty dairy, less red meat, and trying to increase fruits, veggies, healthy nuts, and low fat dairy, poultry, fish. So kind of like a Mediterranean diet is generally what's going to be recommended. They don't recommend low carb or no carb. They just want it to be a more rounded diet. Increase the exercise. That's going to be 150 minutes per week of moderate intensity or 75 minutes per week of vigorous intensity, so like running. We want to quit smoking. We want to limit or eliminate alcohol intake and manage weight. So stay in the normal weight range. Typically, they classify this based on BMI. So then after we try non-medications, if that doesn't lower the cholesterol as desired, generally we move into statins. Statins are very old medications. They've been around for 50 plus years. At this point, they're very, very cheap for the most part. If you're not getting the brand name ones, they can lower your LDL up to 60% for those high intensity statins. They do have varying levels of cholesterol reduction. So we have low, moderate, and high intensity statins. For those patients that we talked about that have had a heart attack, stroke, kind of those severe symptoms, severe cases, we're going to want a high intensity statin, and that's going to be Crestor or atorvastatin. So generally, the higher doses do have the higher risk of the statin associated muscle symptoms. So we can have myalgias, which is just kind of some pain, kind of soreness in your legs generally. It's usually not tolerable for patients. We can have myopathy, so that's going to be more of like an aching, soreness feeling. Myositis is going to be an actual inflammation of the muscle. They can't really tell that though unless we do a muscle biopsy, so it's kind of a severe case. And then rhabdomyolysis is the full progression of these statin symptoms. That's going to be the most severe. It happens in less than 1% of patients generally, but it can cause issues with your liver, and you can generally see changes in your urine, and you're going to be in a lot of pain generally. So statins can also cause elevated liver enzymes. So these are all things that we're looking for when patients are on statin therapy. So there are risks associated with it. The risks are generally low percent of patients, and it does decrease your LDL by quite a bit, up to 60%, as I mentioned. So it is a risk versus benefit when we're thinking about starting patients on these medications. So we're thinking about non-statin therapies. The first thing I like to think about is statin intolerance. So that's going to be these patients who have adverse effects from statin use. So it's going to be generally one of those muscle side effects that we talked about. Can resolve on its own with lower doses or completely stopping statins. To say you have a statin intolerance, guidelines like you to have tried at least 2 statins, and one of them has to be at the lowest dose of the statin. Complete intolerance is going to be you cannot tolerate any statin, at least of those 2, at even the lowest dose. And then partial intolerance is you're going to be able to tolerate a statin, but may not be that high enough statin to meet your LDL goals. So your LDL is not as low as it should be, but we are able to tolerate at least a moderate or low intensity statin. For partial intolerance, we can try alternative statins. We can do interval dosing for some patients, like they'll do a Monday, Wednesday, Friday of a small dose, or we'll do some adjunct non-statin therapy for those patients.
Mikayla, we do have a couple questions.
Sure.
One person said, I had a heart scan that was offered through my insurance a few years back. Are those indicative of heart issues? My test was considered excellent.
So it depends on what the scan was. If it was like a stress test, they can see if the what they're checking for is normal or abnormal. If it's classified as normal, that's generally where the testing ends. They also have a newer test. It's a calcium score, and they can use that in kind of collaboration with, if you had a stress test and your LDL, to see if you're going to be at risk and might need to go past a stress test to like a cardiac catheterization.
Okay, and then the next question is, can statins cause permanent damage to muscle? This person has tried multiple statins. They've been diagnosed with fatty liver, and they've had 2 torn glutes and a hamstring tear as well.
So it's generally not thought to cause long-term damage. Most of the time it's reversible when the statins stopped. But if you were having some sort of issue and the medication was continued while you were having this issue and it progressed, I can't say for sure that it wouldn't cause it. That'd be something to discuss with your provider to see if they think that that could be the root cause.
And then it looks like that test that was performed on that person, it was a calcium score.
Okay, yep. So they generally look at a calcium score. The cutoff typically is 400. So if it's less than 400, they see that this calcium is not built up as plaques in your coronary arteries. So generally, if the calcium score is low, then they don't do any further testing. So that is great to hear.
So the higher the number on that test, the more risk you are for a cardiac event.
Generally. So there are patients that do have high scores and then they do a cardiac catheterization and then they don't even need stents. So it's not like 100% you have a high score, you have a serious cardiac thing going on, but they do kind of use it as a biomarker along with symptoms that the patient's having.
Okay, great. I think that's all the questions for now, but keep them coming, guys.
All right. So some of these adjunctive therapies. So these are going to be more of the standard treatments that we've had for a while. So who is going to benefit from these adjunctive therapies? So that's going to be patients who are uncontrolled cholesterol while on statin therapy. Either you're on the maximally tolerated and you're still not at goal, or we're only on that lower level statin and you're still not at goal. Statin intolerance, like we discussed, so you're on that low level statin and still not at your goal. History of familial hypercholesterolemia. So a lot of these patients are not able to get their LDL at goal with just the statin. So we're going to have to add on another medication for a lot of these patients. And then diabetic patients, like we discussed, they have sort of the risk already with blood sugars can damage the vasculature if they're not controlled. So we want to make sure that we have these patients kind of at a tighter goal so that we are able to protect the vessels as best we can. There's also going to be patients that they might deem very high risk. So if you've had multiple heart attacks or heart attack and a stroke or TIAs, they're going to want you to have your LDL levels lower than the general population. So those patients might be at the normal goal for most patients, but since they've had these events, we wanted to keep them even tighter just to prevent further recurrence. So this first class is Zetia is the only medication in the class. And it's the first line option in the guidelines after statins for lowering LDL. So it inhibits the absorption of cholesterol in the small intestine. This is a once a day medication that you take by mouth. It lowers the LDL 15 to 20%, which is on the lower side considering how much statins can lower up to 60%. This medication is now generic and the side effects are relatively mild. So we can have some elevated liver enzymes, which we follow with blood draws, and then muscle related effects as well. These are also very rarely reported. So the patients who benefit most from studies of this is people who are not using this for primary prevention. So this is going to be for patients who have had some sort of event and we're trying to prevent a secondary event, who's going to be at the biggest benefit. The next kind of class of medications is bile acid sequestrants. So there's a few medications that we have in this class. These can also be used for patients with like GI side effects. We'll use it in the hospital for that. So you might be on it for multiple reasons. So these medications bind bile acids that leads to the increase in LDL receptors. So the more receptors we have, the more LDL we can take out of our blood. So we have less floating around. This can reduce your LDL by up to 25%. So more than the previously mentioned Zetia. It's generically available. These are old medications, can be dosed 1 or 2 times a day. The class comes with tablets and with these packets that you can dissolve in drinks. So there are a couple different options here for patients. It's going to be oral, all of the options. The cholestyramine medication, which is going to be the most common, shows small decreases in serious events in the trial, so that is promising. It can be poorly tolerated with GI side effects, so it can lead to constipation and some vitamin deficiencies. These have to be separated from other medications by a couple hours, so it can't be taken. So it adds kind of to that pill burden and just overall pharmacy burden for patients. This is going to be the drug of choice for patients that are pregnant. It is tolerated in pregnancy, but we should not use it if you have high triglycerides. It can be dangerous for patients with triglycerides over 300. So we do avoid it in those patients.
Got a couple questions, Mikayla.
Sure.
This person said recommendations on the bile packets. Maybe we can elaborate on that. This person's currently on them and they have a history of lymphatic colitis.
Yeah, so it's hard to say. I'm guessing they're probably using it for that lymphatic colitis indication. I'm not sure if they're using that for that or for the LDL lowering. Could kind of be two birds with one stone situation.
Okay, another question here. Consumption of garlic, lowering cholesterol levels.
We will get to that at the end. Let's talk about herbal supplements.
All right, we're good for now, I think.
Okay. Okay, fibrates. These are also old medications. Gemfibrozil and fenofibrate are the main medications in this group. So it reduces the amount of fatty acids available for synthesis in your body. So unfortunately, these medications are going to be minimal LDL reduction, which is that main number that we target to lower cholesterol, but it can reduce your triglycerides up to 60%. So I mentioned that is an energy source that is within your body, and high9triglycerides can lead to high LDL. So we kind of have to treat that high triglycerides first before we can get to the LDL problem for some patients. Generically available, it's oral medication that you take daily. It has not been shown to decrease serious events, so it's not going to decrease your risk of heart attack or stroke, but we can potentially decrease your triglycerides because that can also be problematic. High triglycerides can cause pancreatitis and things like that, which can be very painful and also cause hospitalization. So maybe not decrease risk of death, but can decrease risk of other serious complications. So again, most of these medications are going to go through your liver since that's where we're making the cholesterol. So it can cause elevated liver enzymes, some muscle-related effects, and skin photosensitivity. So for patients on the fibrates, you want to make sure they're wearing sunscreen or covering up their skin as much as possible to avoid getting sunburn. All right, next is omega-3 fatty acids. So this is going to be generally like the fish oil. So this decreases the manufacturing of triglycerides in the liver. So again, minimal LDL reduction, but it can reduce your triglycerides 25 to 45%. It's oral meds, daily dosing. Sometimes I'll have you split it up. Some formulations are available over the counter, but the one on the slide, the sepia, that's a prescription medication. It's only been shown beneficial in certain populations. So that's going to be patients with advanced heart failure and Japanese patients that were in trials that they had conducted. Those patients did have the most benefit. So a lot of people will start over-the-counter fish oil, and they might not be the prime target population the trial was studied. So this can cause GI upset, and you can kind of have fish burps is one of the most reported side effects. So it's really unpleasant. It's not harmful. And then we're going to have the potential risk of bleeding. So you need about 4 grams a day to have the major triglyceride lowering effects. So you can see that bottle is 120 capsules. So that lasts 1 month. But we can have risk of bleeding if we have more than 3 grams a day. So it's going to be a fine balance. And it's something that you really want to talk about with your doctor before you just start it over the counter. So niacin, it's also an over-the-counter medication. There are prescription formulations. So it inhibits an enzyme that plays a key role in production of cholesterol. This does lower your LDL. It's variable. Usually most of the different formulations are 15 to 25%. It's oral, daily. And again, this one, because of the low reduction, it's not a consistent LDL reduction in the trials, has not shown to decrease serious cardiac events. Many patients cannot tolerate it. It does cause flushing for some patients. So kind of like when you feel warm, you get red. It's not harmful, but it can be uncomfortable. So to avoid flushing, they can recommend taking aspirin, but then you're kind of adding to your pill burden. So we're adding niacin, then aspirin, and we don't want to have aspirin added on to patients for no reason. We have found in the recent years it is not as benign as we thought, and we only want patients who really need it to be getting aspirin. So that is kind of something that you can do to offset it, but most people probably would not recommend it at this time. It can cause increased glucose levels and, again, some GI upset issues. So it is something you want to talk to your doctor about. I would not start this over the counter just without talking to anyone. In the most recent 2018 cholesterol guidelines, they don't recommend niacin specifically. They don't say it's not recommended, but they don't recommend it as one of the first options. It is widely available, though, so it is something that patients might start, but you do want to discuss that with your doctor for sure.
What is the recommended dosing for that on the niacin? Is it 500 milligrams?
It's widely variable. So the trials have tried usually 500 to 1,000, but there's no standard dosing. So these emerging treatments, they're pretty interesting. We have quite a few that are coming out. So the first class is the PCSK9 inhibitor. So these have been out for a few years now. So there's synthetic antibody that inhibits a specific enzyme that binding to LDL receptor. It increases number of receptors so then we can bind more LDL. So in studies, it was combined with statins and it reduces your LDL by up to 60%. So that's major for a lot of patients. Unfortunately, it's brand only right now and it's relatively expensive. A lot of time it requires a prior authorization. So your doctor has to tell the insurance why you need this medication. So it has to be usually you failed statin therapy or you're not at goal in addition to statin therapy. If you go to a cardiologist within North Kansas City system, North Kansas City Hospital, we have a team that works on prior authorizations for the cardiologist. So if you need this medication, we do work really hard to try and get that covered for you. It is an injection and you can be given it either every 2 weeks or every 4 weeks. So that is a little bit nicer too, can decrease your pill burden, but it does have, of course, a side effect, could be a injection site reaction. So it might have a little redness, irritation where you inject the medication every 2 to 4 weeks. Next is the ATP citrate lyase inhibitor. So it's bempedoic acid is the brand name. In this bottle that is included in the slides, it has that new medication in combination with that Zetia medication for further LDL reduction. So it inhibits cholesterol synthesis within the liver, and we can reduce the LDL by up to 30%. So this is a daily med, brand only, unfortunately, oral. And this one does have kind of more severe side effects. So we do have gout flares as a risk, and then tendon rupture. So the tendon rupture was low, about 0.5% of patients experienced it, but it is severe. It could be in the bicep, Achilles, and that's a really big deal if we do have to have any sort of repair on that. So it's something that the doctor would really take into consideration to start this medication. The next is small interfering RNA molecule. It's inclisiran. So it increases the LDL receptors on the liver to decrease the LDL in the blood. It can decrease LDL by up to 50%. This one is also brand only right now. It's nice though, because we give you your first dose, then 3 months later you get another dose. And then after that, it's going to be every 6 months. So you only have to eventually get this twice a year. So that can be really nice for patients as far as adherence goes. Again, the biggest thing is going to be injection site reactions and the cost associated with it. So it's something that will likely require a prior authorization from your doctor through the pharmacy if they go with this route. So these next two medications, they are special. They are orphan drugs. So orphan drugs are medications that are made for an orphan disease state, and that means that it's rare. So it affects only a small amount of patients. So the FDA kind of helps and pays for the funding of these meds to get it under production so that we can help these patients, because otherwise it wouldn't be profitable, unfortunately, for the drug companies. So they likely wouldn't move forward with the medications, so that the government gives them help to develop these medications. So these are both for familial hypercholesterolemia. So these medications both do have REMS programs, which we'll talk about in a second. So this first one is an ApoB synthesis inhibitor. Mipomormessin is the medication, and it reduces the formation of the main component of LDL. The reduction is only about 25%, so that is a lot less than we have seen from the other potential medications. It does have that REMS program. It's brand only and a weekly injectable. So the reason it requires a REMS program is because of the liver toxicity. Other than the liver toxicity, it's relatively mild, the injection site reactions, and you might have some flu-like symptoms. Oh, I skipped one. And then the second medication, and this it's an orphan drug, is a microsomal triglyceride transfer protein inhibitor. So it prevents the assembly of the cholesterol components. So this medication can reduce LDL by 40 to 50%, and it has that REMS program because it's specifically for familial hypercholesterolemia. So it's going to be brand only, and it's a pill you take every day. It does have liver toxicity as well that requires the REMS program, and you can have some chest pain, which is a little concerning for patients, as well as GI upset. So what is a REMS program? So basically what a REMS program is when the medication goes through the process with the FDA, they are seeing that there's a potentially big side effect that is harmful to patients, and we need to have a risk evaluation and mitigation strategy. So it makes sure that the patient and the prescriber and the pharmacy are all doing the ideal behaviors so that the medication is as safe as possible. So it's generally for a specific risk. So for these medications, it's for that liver toxicity that we can get. We can have kind of like a fatty liver develop from these medications. So we need to be very vigilant about that. So for the prescribers, they have to complete a training module and complete an enrollment form. They usually have to keep up some sort of training to make sure that there's any developments there on top of that. And they have to agree to counsel all the patients on the hepatotoxicity or liver toxicity of these meds. For the pharmacy, all the staff has to complete modules as well for learning, and then agree to make sure that the patient is being, again, counseled when they pick up the medication, and that they're making sure that the doctor does, in fact, have the certificate. So it's on the pharmacy to make sure that the doctor can prescribe this medication. For the patient for these medications is agreeing that they're going to get the scheduled lab work and that they have been educated on the risks that go along with the medications. So when we're looking at comparing the options, the biggest things we generally look at is going to be costs for patients. So the few we talked about at the beginning, it's kind of gone up progressive. The older medications are cheaper, as it usually goes. So Zetia and fibrates are usually on the lower side. Bile acid sequestrants are also kind of in that median range. The fish oil can be low if you get an over-the-counter formulation, but if you get those prescription formulations, they're a lot more pricey if you don't have insurance. And then it goes up exponentially from there. These other medications cost anywhere from $1,000 to $60,000 a month without insurance, but it can be quite a bit. The highest one is going to be that last one we talked about with the for familial hypercholesterolemia. So most patients won't need that one, but it is something to think about. So as far as LDL lowering goes, we do Zetia. That's relatively cheap and easy to add on for most patients. So we can get another 20% lowering. A lot of patients, if we're at high risk, if they've had events, we do want to try the PCSK9 inhibitors because we can get up to 60% in addition to the statin therapy. These other medications are kind of lower. The last two are going to be only for those familial hypercholesterolemia. 50% is great too with the inclisiran that's only twice a year. So you're going to see generally a higher LDL reduction with the injectables versus the oral medications. So the frequency, most of these are daily as far as the orals go. And then those injectables are nice. We can do bi-weekly, monthly, or even every 6 months with that new one. And then the biggest contraindications for some of these medications is bile acid sequestrants. If you have biliary obstructions, we can't use those. For fibrates, if you have poor renal function or really poor liver function, we can't use those medications. And then those last two we talk about that are in the REMS program, you can't have liver disease for those. So we're going to be monitoring that very closely. So we're also going to be needing to think about what's going on with the patient when we're thinking about adding on a medication. So where these two say minimal LDL reduction, the fibrates and the fish oils, those are going to reduce your triglycerides. So if you do have high triglycerides, those are going to kind of be where we go for you. If you don't have the high triglycerides and it's strictly LDL, the fibrates and fish oil don't make a whole lot of sense for those patients. So herbal supplements, we did have a question about some herbal supplements. So the first one is ubiquinone. It's also known as CoQ10. So statins deplete CoQ10 by interfering with its production. So some patients, when they're on statin therapy, they are CoQ10 deficient. Generally, we don't test for that standard while patients are on statin therapy. There has been conflicting meta-analysis data. So a meta-analysis is we compile lots of large studies and we see, when we compare all these studies, did it show benefit, no benefit, risk, essentially. So there's two big meta-analysis, and one showed that CoQ10 really didn't help at all with the muscle pain and ability to take statin. And the second one showed that patients were able to tolerate statins more frequently when we gave them CoQ10. So the evidence is more anecdotal at this point, that if some patients that can't tolerate statins, their doctors will start them on CoQ10 to see if that can replete their levels and they're better able to tolerate statins. So this is to help with statin tolerance. It is available over the counter, but I, again, would definitely talk with your doctor before starting this. The evidence kind of is back and forth, so it's not recommended by guidelines. So it would be a conversation that you would want to have. So other herbal supplements are generally not recommended. As far as the big cardiology groups concerned, the national groups, there's no added benefit and you can cause some actual harm depending on which medications you take. Most of them are not regulated in any way, so it might say 100 milligrams, but no one's testing to make sure there's 100 milligrams. There could be 5 milligrams, there could be 200 milligrams. We don't really know. No one's checking. And these also do come with possible drug interactions with your medications. So the biggest one I worry about for patients is warfarin. If you're on warfarin, a lot of these herbal supplements can affect your warfarin, your INR levels. So we definitely want to avoid any herbal supplements without talking to your doctor while you're on warfarin. And then there was a recent study that was published this year that compared some of the most common herbal supplements that patients use over the counter. So this little chart here, the blue on the very left is Crestor, that high intensity statin, but at the lowest dose. So only 5 milligrams a day. And so you can see that the Crestor group had 37% reduction in their LDL in over only 28-day period. So that was quite a bit. So all of these other bars are the other medications that they tested. So we tested fish oil, a placebo, cinnamon, garlic, turmeric, plant sterols, and then red yeast rice. So none of these were statistically significant compared to the Crestor. So Crestor had significant lowering. The other ones had no significant lowering. It is something to think about. This is only a 28-day period, but based on this data, it kind of strengthens the argument that these over-the-counters aren't really doing necessarily what we think that they're doing all the time. And you can see in the garlic and cinnamon, it actually increased the LDL levels a little bit. So that's also concerning. We don't want to increase those LDL levels. The side effects were no different in the Crestor, the prescription medication, versus these other medications. There was 2 severe side effects that were reported, and one was in the placebo group. So we know that that wasn't from medication. And the other one was the fish oil group. The person actually had liver cancer, but it was later reported that that was before they even started the fish oil. So it wasn't from the fish oil, but there was no significant adverse reactions with the medications. And so it kind of just strengthens the argument. There wasn't even any reported muscle aches with the low dose Crestor in this study. So it was relatively low numbers, about 25 to 30 patients in each group. But we did see promising data that the statin therapy can be helpful, and these over-the-counters can maybe be harmful, especially with the garlic that had the increase in LDL. So when you're thinking about starting any of these medications, you definitely want to make sure that you talk to your doctors, because all of these over-the-counters you can get, obviously without a prescription. They do have interactions sometimes, warfarin, and then those specialty medications, like if you're on any medications for like chemotherapy or rheumatoid arthritis, those are kind of the high-risk medications that I worry about these drug interactions. So it's also kind of just costing you money, and you're not really going to get any benefit. So some of these are kind of pricey over-the-counters as well, like, you know, $20, $30 over the counter, and it's not really helping you. So it's better to just save that money and talk to your doctor about potentially medications or dietary lifestyle changes that we could do to further lower cholesterol levels. So that's what I have. What questions do you guys have?
I have a question. You know how quickly our cholesterol levels change? You know what I mean by that? Like, how often is that going to fluctuate? How easily is my cholesterol, my LDL, going to drop 20 points based off of the diet choice I've made?
So generally, we have to wait at least 4 weeks to recheck levels. Most providers will wait 3 months to recheck levels. If you're just kind of in the borderline range, they might even wait 6 months to a year to recheck.
How do I know if I have the familial high cholesterol?
Yeah. So
that versus my family's just got high cholesterol from diet choices.
Yeah, so that's a really good point. So every time you come to the hospital or go to a doctor's appointment, usually they ask you family history questions. So a lot of these patients will have early cardiac death from their relatives. So what that is like males less than 55, women less than 65, either having serious cardiac events or cardiac death. And if you have multiple family members, then you can do genetic testing to see if you have the familial hypercholesterolemia. But they usually do a kind of a thorough background with family history to kind of get that first ball rolling. I think you're muted.
You're right. Rob, do you have a question? Tried to unmute you. Okay, well, we got some other ones. Here's most of the other options of medication for cholesterol besides statin should be avoided for a person with liver issues. Would you agree with that?
So it depends on even statins have the risk of liver toxicity. They all are going to stop that, the production of cholesterol within your liver. So it kind of depends. We have to balance what that liver issue is and if it's acute or a chronic issue. So they'll do the blood test and look at your liver levels. So sometimes we look at the severity. So you might have slightly elevated and they might continue the medications. We also look at, there's a scoring we can kind of use, which is usually like severe liver disease when we absolutely cannot use the medications. So the doctor really will look at what the levels are and your symptoms to see if these medications going through the liver are okay or if they're not okay, because even the statins do have to go through the liver.
For you to share your slides, is that something you'd be willing to do?
Share the slides? Yes, I can do that.
One more question here. What is the test for multiple family members with heart issues? This person's brother and father have both passed away at 47.
So, as I mentioned, my dad had open heart surgery a couple years ago, and his mom passed away early, and my uncle had also passed away early. So what they typically do is we're going to start by getting your cholesterol level, see where you're at, and then they'll probably, depending on where you're at, they'll monitor them closely. So if you have if you're within normal limits, they'll just keep monitoring you closely. If you have elevated cholesterol, they might need to start you on a statin or one of these other medications to make sure that we prevent as best as possible. If we're seeing the early cardiac events, they could do the genetic testing for familial hypercholesterolemia as well.
Great questions, guys. Anybody else got one? Well, I learned a lot today, Mikayla. I appreciate that. That was a great talk.
Thank you.
So what I will do is I will send everybody that's registered the recording of this YouTube link, and you can watch this at a later time. Mikayla's also okayed us to share her slides, so I will include that in the email, her slides as well. Since we're on the topic of cholesterol, one of the things I do frequently in my role here at the hospital is I do health screenings, including cholesterol and blood sugar checks. And so I run around town, go to community centers, churches, done some farmers markets, things like that. Those are all listed on our webpage. So if you go to nkch.org/class and search for the biometric screenings, there's several located and they're all free. So great way to just have a little spot check. We do your total cholesterol and your blood sugar, and we'll check your blood pressure, and we just do a little chat. So keep that in mind, pass that on. But yeah, thank you so much, Mikayla. You did a great job. You're a good speaker. Well, if nobody else has questions, I hope you guys have a great holiday. And thanks for tuning in.